together and then they take care of themselves.
Hi, everybody.
Krishna, too good. Hi.
Hi, Agam. How are you?
Hello,
Hi,
everybody.
Agam.
Hi.
I'm
Agam.
sorry, yesterday I disturbed you. I think I missed off a meeting. I think I disturbed you a lot.
The standard answer we give whenever somebody says that sorry we have disturbed you, sir, शादी शुदा आदमी है, already disturbed you, don't worry about it. इससे ज़्यादा disturb नहीं हो सकता.
इतना घिसा पिटा हूँ और नहीं घिसा पिट सकते हैं. Welcome, Anand.
Okay.
Hi.
So, shall we
नमस्कार,
start streaming?
भावे सर, नमस्कार.
Yes.
Namaskar.
नमस्कार सर.
Hi, Dr. Bave. How are you?
Hi.
So everybody's
shall we
there. I
start?
think we can start. Yes.
Yes, Krishna.
Good evening. And one Praveen. Praveen is off a fan. Thank you. Good evening. We're ready to rock. Welcome everyone. My name is Dr. Krishna Sheshadri. I help curate these programs for GCCMC. GCCMC, as you know, is a CSR of Wipro that has been created during the COVID-19 pandemic. It is interesting that we still consider ourselves to be relevant to exist. Much water has flown through the Coombe and all the other major rivers in the world, and we are still talking about COVID-19. What we have done during this COVID time is create a platform where we have brought in the best minds of the country. As we spoke some time ago, there has been a shift from evidence-based medicine to emotion-based medicine in the last 2 years. And therefore, the important thing is not to panic, to work with what experts work with what experts are doing, and use the collective wisdom of the clinician and the clinical polity, and not necessarily be swayed with economics and the epidemiology of this. Right, as Yudhishthira said in the Mahabharata, "Dharmasya artham nihitam guhaya." That is the nuances of dharma are very, very huge. So the way to do is to follow the path of the wise. So we have some wise people here today. Again, we think we are in the tail of the epidemic, but we don't know what is going to happen. And they are going to guide us through, make sense of the huge preprint RBX that everyone is reading and everyone is quoting, and actually distill it out into what should clinicians do, what should patients do, what should we do as a whole. And today we'll talk about Omicron, Delmicron, and all the thicknesses that we have heard about in the last few months. And to lead this, we have a very, very senior, well-respected mentor of the clinical community in India, Dr. Vijay Negalur. Dr. Vijay Negalur brings in a tremendous amount of experience, a lot of grounded knowledge and wisdom, a teacher of teachers, and more importantly, a most very, very human and genial person to have in our midst. And he's brought together a beautiful panel. Some of these faces have already been part of the GCCMC platform. Each of them is a toy in their own right. And I think we're going to have 90 minutes of exceptional learning. Please send your questions in. The panel will be able to answer it. After all, you know, this none of them have a problem saying I don't know. So please send in all the questions that you want, and please learn from this exceptional panel. Dr. Negalur, the floor is yours.
Thank you, Krishna Sheshadri, and of course, Dr. Vijay Shetty, for your kind opportunity for me to steer through this kind of a discussion on Omicron. I feel it's a great honor. And once again, thank you very much. To begin today's session, I begin with this quote of Sir William Osler, who said that humanity has three most great enemies: fever, famine, and war. And of these three, by far, the greatest and by far the most terrible is fever. And we all of us are experiencing that since last 2.5 to 3 years. As we know, till February 1st, 2022, we have more than 377 million patients across the globe, out of which 56 million patients lost their lives to this pandemic. And recently, on 11th of November 2021, at Gauteng, that is a province in South Africa, and which has these important cities like Pretoria and Joburg or Johannesburg, saw the new variant, which was called Omicron, and the biological name is B1.1.529. And this, for the public, for the non-scientific community, is Omicron, which was labeled by WHO. And as expected, it spread like a wildfire. It spread to Belgium, Israel, Hong Kong, Italy, and eventually all over the world. 2nd December 2021, these 2 cases were reported for the first time from Bengaluru, from where Dr. Krishna Seshadri is coming from. So the wisdom lies in Bangalore, where they picked up this patient for the first time, these patients of Omicron from India. So the 3rd year of the COVID pandemic has brought some harsh truths and some realities and few glimpses of hope. And to discuss about this in all details, we have 3 talented people to discuss this across for next 90 minutes. And just to introduce them, Dr. Mangesh Devaskar is a great friend of mine, who's a diabetologist and a physician at Karuna Hospital. He's the General Secretary at the API and ICP. And of course, he's the most well-read person I heard. He is so much into passion of giving lectures and talking about the most difficult subject, making it simple. And so we expect a lot from him today in this discussion about Omicron.
Thank you.
The next is Dr. Agamora, whom also I don't know much, but I've heard him a lot. He is very active member of the API. He is a pulmonologist and the intensivist from Karuna Hospital again at Borivali, and also at Manav Kalyan Kendra and Suchak Hospital again, I think at Borivali. And my close friend from Thane, a very reliable friend, and he also looked after me when I had COVID myself. He used to console me, give me all kinds of courage and strength. And he's a physician and intensivist from Thane. He works at Jupiter Hospital and also his own hospital at Param Hospital in Thane. So with this kind of panelists, I think we'll get started with the discussion. And I think we will start in the order of seniority or whatever. But I feel the first question I would like to ask Dr. Devaskar himself is what is this mutation? And why do the viruses undergo mutation? And the nomenclature I said about B1.1529, how it has come, what is this pangolin way of nomenclature, and what is this Omicron all about? Can you just begin introduction? And before you begin, Mangesh, I will have a small request to all of you. Be as precise as possible. So we have many questions with us so that we can see through all the questions if you're very precise and to the point.
Yeah,
Mangesh.
Sure, sir. Sure, sir. Good evening. Sir, thank you very much for this beautiful opportunity. Now, before I answer that question, I would like to appreciate Dr. Krishna and the entire team, Dr. Vijay and the entire Wipro team for this nice opportunity. And very good evening to Dr. Bhave and Agam, my very close friend. Now, Neglur sir, as Dr. Bhave was to you during your COVID times, it was Agam for me during my hospitalization with COVID. Okay. Now, as the question, sir, has said, what do you understand by a mutation? Now, it's a very tricky and I would say a phenomena that occurs in the microbes or in the bacteria or in the viruses, where there is during either the process of evolution or during the process of multiplication, there is an alteration in the genetic structure, which can either get damaged or changed because of either the environmental factors or the host factors, and it differs in the genetic message carried by the gene. Now, that is actually the technical definition of mutation that we all know. This is what I have tried to simplify. Now, as far as the nomenclature is concerned, now this B1.1.529, which we popularly know as Delta, primarily is one of the ways of nomenclature which has been derived from a team which is called as the Pango Nomenclature. Now, Pango was for pangolin. So pangolin was taken up for the nomenclature of these viruses. Now, entire microbiological community or the microbiologist community, whenever they want to label the various bacteria or viruses or pathogens and their mutations, they come out with nomenclatures. As if you are aware that during the in the influenza time, there was something called as GI-SAID or GSAID, where this was a global initiative on sharing all data of influenza. So that was a GSAID. There is also a next step, which is again the nomenclature for all the pathogens which is used. But then when we talk about this nomenclature, B1.1.529, this is primarily a Pango nomenclature. Now this Pango nomenclature is specifically derived for the COVID viruses to nomenclate and to know about the COVID viruses. Of course, the WHO virus committee, working committee has simplified it to the Greek names of alpha, beta, gamma, delta, we all know about it. But Pango nomenclature has given this B.1. And what this is this? B stands for the strain or the place of the origin. Now let us understand that B stands for primarily the place, or I would say the ancestry. So it's a cluster of infection and it represents the ancestry of the origin. And then dot stands for the descent of the particular ancestry when it mutates or when it changes the forms. And the next dot, again the same descent of form from the same dot. Now it is usually between three nomenclatures. So B.1.1.1, that's all. You cannot have another dot at one, because that will become too complicated nomenclature. And that is the reason why, it is limited to just B.3111 or three numbers which will be given. Always remember that there are right from A to Z, all the numbers are usually used except O, except I, and except X. Now O and I cannot be used because they can confuse with numeral 1 and 0. That is the reason why they are not used primarily. And X is usually reserved for some specific labelings or the change of strains. This is how I've tried to simplify it as far as the nomenclatures are concerned. Sir.
Right, absolutely right. You're right, because this is how we have Pangolin link of classification, which is used by the medical community. And the nomenclature like alpha, delta, gamma, and Omicron are for the non-scientific community that is designed by WHO. All right, very nice. And it's only RNA virus which undergoes mutation, because if you see the DNA virus, for example, if you see hepatitis B virus, you hardly see any mutation in those. So it's RNA virus, which for its survival has to undergo mutation. So I think let's come to Dr. Agam now. How Delta is different from Omicron?
Thank you very much, sir. At the outset, I must thank you for giving me this opportunity and allowing me to share dais with my close friend, Dr. Mangesh Srivastava, you and Dr. Bhave. Now, variants, as you know, the viruses, it is their desire to survive. And these are the ways to probably paralyze the existing system. So whenever there is a new variant, you're looking at whether there is any change in the transmission capacity of this virus, whether there is any change in the disease behavior because of this mutation, and whether your current diagnostic, your current treatment options are still valid, or preventive measures like vaccines are still valid for that particular variant. When we came across this new variant, that is Delta, Omicron, it had a different presentation compared to our experiences earlier. This particular virus had very quick spread. I would expect 5th or 6th day where family members start getting infection, but here on same day or maybe next day, the family started getting infected. So probably it was very fast transmitting from one patient to the other, from one person to the other. The loss of taste and smell, which I saw, or which was the hallmark for earlier presentation, was to the extent absolutely missing in this variant. The hypercoagulability that we saw with previous variants was missing in this variant. And most of these patients presented only with upper respiratory. They had severe cough and fever and malaise. Luckily, very few of them had pulmonary involvement. So they had cough, but they did not have breathlessness. They did not have hypoxia. So that was the typical different presentation that I saw with this variant compared to the variant. Thank you very much.
Yeah, great. I think you're right. This is more of upper respiratory than lower respiratory. So the CT scan would not show the ground glass appearance, which otherwise you would have seen in a Delta variant. I think we'll move ahead with Dr. Bhave. Doctor, the WHO classification calls the variants of interest and variants of concern. Now, they have said that Omicron is a variant of concern. Why do you say that? Why are we concerned about?
Yeah, as Dr. Agam just pointed out just now that the variants may be, practically infinite. So many different variants can arise. But which are the variants which have to be noted or watched with concern? They are the ones which have some significant differences. That is, either they should be more transmissible, or they should be, or if they are more virulent or more pathogenic, or if there is so much change that certain therapies like say monoclonal antibody therapy, or if antiviral therapy is not so effective, again that is a condition for that variant to be labeled as variant of concern. Or if they show a phenomenon of immune escape, that is, if the previous vaccination or if the previous infection does not protect the person from contracting this infection by a new variant, then even if any of these conditions are fulfilled, then WHO will label that as a variant of interest or concern. So
Right.
definitely in case of Omicron, the condition of increased transmissibility is satisfied, and condition of immune escape is satisfied, in the sense that previous infection or vaccines may not protect from infection in the case of Omicron, although the condition of increased virulence is not satisfied, thankfully.
Yes, I think you're right. And that's the reason why the WHO said that we are concerned about this variant. Now, Dr. Mangesh, why does it spread so fast? How it is different in terms of its attachment to the ACE2 receptor? Is it the same as the Delta, or is it somewhere different? Because the rate at which it is spread, if you compare with, say, measles virus, it is measles supposed to be the one which is fastest. It's
yes.
as close as that. Why do you feel that it spreads so fast, so rapidly?
Yeah, so that is a fantastic question, sir. In fact, that was the question which has haunted most of the medical community. But a very interesting study was done in Hong Kong, where they did ex vitro culture of the hamsters, the upper respiratory tissue as well as the lung tissue. And they found out that this Omicron variant, binds to the epithelium very well in the upper respiratory tissues, and it does not actually interact with the ACE2 receptors. Now, the possible explanation for this is what we call it as, now most of you have heard about it, is the S gene dropout phenomena. Because we know that on the spike protein, there is something called as an S gene, which is actually responsible for binding of these to the ACE receptors. And ACE receptors are usually in high concentrations in the type 2 pneumatocytes of the lungs inside, and pneumatocytes are not there in the upper respiratory tract. So what happens is that this virus multiplies there nearly 50 times faster than its previous predecessor Delta virus, and that is the reason why the multiplication is rapid, and that's the reason why it gets transmitted rapid, because it can easily get transmitted by the droplet infection or through the fomites. And that is what is the difference. The difference is what we know as ACE gene target failure, which has been diagnosed usually on the RT-PCR. We'll discuss about it little later on if the time permits. But this is the reason why it is more transmissible and less virulent, or I would say less immune harming.
I think I listened to Angeline Coetzee, who was the first to identify this virus from South Africa.
Yes.
She says it has a double way of penetration, route 1 penetration and route 2 penetration. And that's where the replication is pretty fast. Route 1 is classic.
And the thing is, another change that has happened is the epitope distribution, which has, clustering of the epitopes on the receptor binding proteins and at the spike protein area has definitely different than the Delta virus. And that S gene dropout is one of the most important, because this S1 gene, which is most important for the ACE2 interception and the entry of the virus into the cell, is definitely much lower in Omicron case than the Delta case.
Yeah, I think according to her, there are two ways of entry into the cell. One is through TMPRSS2, and the second is through the endocytosis. So these two mechanisms are operational. That's why the hypertransmissibility of this is because of this pattern of a double penetration into the cell. And that's why I think it spreads very fast. I think coming to Dr. Agam again for the next question, you have said about the symptoms of upper respiratory and the other one, Delta, you said lower respiratory, but how do you actually suspect clinically? What are the clinical features which are very peculiar for the Omicron? Clinically, how can you suspect that this is Omicron, but could not be a Delta variant? Because we know that there is still Delta variant going on. At least you must also be seeing in your intensive practice, there are patients also. But of course, in USA, they've said 98% it is the Omicron. But I think in India, in certain part, it is still Delta which is going on. In West Bengal, they did the genomic sequencing. They said 80% was Omicron. But I feel in the southern part of India, it is still Delta ruling. So clinically, how you suspect one from the other?
I completely agree with you, sir. Though in what we are seeing in OPD now is all Omicron, but patients who require hospitalization, they may be Delta variant. We have not been able to do genome sequencing. We may not be able to, not been able to identify this, genomes in most of these patients because of not easy access or delay in diagnosis, etc. A couple of issues are there. But clinically, if you ask me, I would suspect that when patients tell me that taste and smells are maintained, when they tell me they have severe myalgia, very high-grade fever, upper respiratory symptoms, throat irritations, maybe ulcers like feeling in the throat, and they have cough, they have less of breathlessness, they have no hypoxia. And when, if you get chance to do the CT scan, because most of these patients in my area do their CT scans and then only contact us. So when they do their CT scans, the scans are by and large normal. In those situations, I would suspect, Omicron. But in otherwise situation, when patient complains of shortness of breath or when there is hypoxia, I would think in terms of Delta. But trust me, clinically it would be risky to label somebody as Delta or Omicron on day 1 or day 2. You may be able to confidently say that on day 3, day 4, when as per the disease behavior. And one has to be extra careful. One has to be equally careful when you're dealing with Omicron or when you're dealing with Delta, because I've had enough patients who had only Omicron, but they have so much of comorbidities that just the presence of Omicron could put you into that decompensation. Imagine a patient of COPD who's on oxygen therapy. Even if he gets mild viral infection, he's going to be pushed into acute exacerbation of COPD, which is going to require hospitalization. Imagine a patient of CKD on dialysis. A trivial infection can push them into acute renal failure on top of chronic renal failure. Hence, one has to be extra careful or equally careful when it comes to people who are elderly, people who have comorbidities. Thank you.
Would you like to consider also the state of vaccination? A large number of people are still unvaccinated. If you feel that the person unvaccination comes to you when you think of again, whether it's Omicron or a Delta?
Yes, I missed that point. Very well, sir. Very well.
Okay. All right. Very good. I think coming ahead, Dr. Bhave, the Rtpcr test is what we do routinely. And this test comes positive on which day? And when you test whether it's throat swab is better or the nasal swab is better, which one has a better yield or both are same?
You need to unmute yourself, sir. You need to unmute yourself.
Anand, unmute yourself.
Yeah, test can be done from nasal swab or from the nasal turbinate or nasopharynx or nasal washing or even from saliva or throat swab. And even a combined nose or throat swab together can be done. Generally, the oropharynx, that is done from the mouth touching the back of the throat, is slightly less sensitive than the nasal swab or the nasopharynx. And saliva is also quite sensitive or easy to pick up. So RT-PCR overall has a sensitivity of at 70 to 80%. We still can miss 25 to 30% of the cases even with RT-PCR. Generally, earlier in the illness you do the test, the more the chance of picking up. So probably the first 3, 4, or 5 days of infection, you are more likely to get a positive RT-PCR result. Later, that is the viremic phase or viral multiplication phase of the illness. And as you go further into the disease, after 7, 8, or 9 days, then the chances of an RT-PCR coming positive may reduce. And especially if the patient has come to you first time with already developed a pneumonia, etc., then sometimes you may have to try to get lower respiratory samples like cough, sputum, or even bronchoalveolus samples. By that time, the upper respiratory viral load may reduce.
Yeah, again,
So,
another little more extension to that. There are a lot of
Yeah.
people who take biotin. This
Yeah.
biotin uses supplement by people who need to grow their hair. Biotin also used by neurologists to treat their multiple diseases. And it's also available on the counter product. Do you think that biotin will affect this RT-PCR testing?
Well, I'm not really aware of this. What I have read is that it is used in the process itself, or the test kit, RT-PCR test kit. Biotinated test kits are more sensitive, but I'm not aware of dietary biotin affecting the reports.
Yeah, I think there are some studies which looked into this aspect and they said biotin does not. It's interesting to know that the biotin affects the thyroid function test. If you take biotin for just 1 week and give you a thyroid function test, your thyroid function report will come as thyrotoxicosis, though you're a euthyroid. So therefore, there's a red herring when you look at the patients of thyroid function and they have abnormal thyroid function, then you always ask this history of consumption of biotin. But the RT-PCR is not affected by it. There's definitely, it has been pointed out that it is not affecting.
Yeah, sometimes, sir, just to continue, the single dose of biotin will not affect, but probably if somebody is on with a prolonged biotin therapy, you need to be a little careful whenever you are interpreting the results, especially negative results.
Okay. So again, Mangesh, you stay there. There's a question for you. The antibody testing. A lot of people test the antibodies routinely. They come flash their reports to you. Has any relevance to it? Is it necessary to do antibody? If so, when would you do it? If not, why it's not important?
See, antibody testing has been popular primarily as a rapid diagnostic home test where people are not able to reach the RT-PCR centers, or when the tests were not possibly easily available at the places where these rapid antibody tests have been proved to be positive. So very important, as Dr. Bhave has already pointed out, that as RT-PCR there is a chance of around 25 to 30% negativity. Same way RT-PCR also has got less sensitivity. But whenever it is diagnosed, it is more specific, and understand that there is a possibility of around 30 to 40% negative test till the patient can be COVID. So that is the biggest aspect. Now, this is a very popular home testing tool, which has also become popular in most of the patients. Many of the patients, even now in my practice or in Agam's practice, I'm sure they come out with the RT-PCR, or they do RT-PCR and then, the rat test, and they call us, sir, that I have done a rat test, this is turned out to be positive. So once the test is positive, that is for sure you need to treat it as COVID. But negative rat does not rule out COVID. That is very important to understand.
I think, Mangesh, we're talking about antibody, not antigen.
Yes, I'm
what
talking
is
about
rat is
antibodies.
antigen.
Achha, you talked about antigen testing.
Antibody. I'm talking antibody only.
Okay.
People see, when they take vaccination, they take antibody.
Okay. I'm sorry.
Or when they get infection in the past, they want to know how much antibody response they have got.
No, honestly speaking, I don't feel so that is necessary for doing that, because of two reasons. Now, yes. I can tell, and I can quote easily my wife's example. After vaccination, initially she just went in her place of work, and they did all that IgG antibodies, and the titers, in spite of vaccination, were very, very low. And she was very upset. I did not generate any antibody response to the vaccine and all that. So I told her that you need to do a specific antibody test, if at all you need to know. And then she went out and asked for the specific IgG antibody test for the SARS-CoV, and that has turned out to be high titers. But honestly speaking, whatever the antibody titers that we are estimating these days, they are not truly very specific or representative of the neutralizing capacity. So I don't feel so antibody titers should be the part of the investigations as a routine. In a very, very, very select situations, probably you may call for antibody titer, but I do not recommend in my clinical practice the regular estimation of antibody titers.
Sir, if I may add,
and Agam, in fact, in the vaccine determination phase, where people want to get vaccinated or not, should I take vaccine or not? My antibody titers are very high still. It's an absolute, I would say, deceptive way of interpreting it.
Yeah, Agam. what you have to add something?
Sir, when patients come to me with this kind of report, the way I explain them, it's like a big orchestra going on. Your immune reaction or your cytokine storm is like a big orchestra going on. There are so many instruments playing. There are so many things happening at a time. And you're focusing only on one thing. You may pick up just one antibody titer and would want to know whether your immune system would work well. It doesn't happen that way. It is actually the functioning of entire unit, entire body when there is infection, and targeting on one particular aspect of it may not be wise. I would probably give that message to the audience who's there today. Please waste no money and no time on asking for this test. And if this tests are bought to you, please spend no time in interpreting this test. Thank you.
Absolutely.
Anand,
may I-
any difference of yes.
Yeah.
Anand.
Yeah, as a physician, when I would ask for antibody, basically there are very few situations. Supposing the patient has come quite late, patient has a pneumonia, it's second week of illness, I'm not getting the Rtpcr positive, and I want to try to find out if patient has been infected or not with COVID. Then at the second or third week, perhaps a COVID antibody would be helpful to suspect. A positive antibody test would be helpful to suspect that this pneumonia is maybe due to COVID. Supposing somebody has been vaccinated by a spike protein vaccine, like say Covishield, then the patient is expected to generate anti-spike antibody, but the patient will not have anti-N antibody. Both are available to us. So in a patient like that, if you do an anti-N antibody and that's positive, then he has been infected also at some time in the past. Now, antibody titers will drop with time, so whether it's after a vaccine or after an infection. So as few months pass, the antibody titers are going to drop. And we do not have still confirmed data that what is a protective antibody titer. So how much antibody titer is enough to protect you? That data is not there. So that is why we don't recommend, just to find out whether you are immune or not, do antibody test. That is not useful. But another situation that I would do an antibody is when you are suspecting a post-COVID inflammatory syndrome. Now, even in adults, now we see cases of multisystem inflammatory syndrome in adults, MISA, just like there is an MISC in children. So MISA, if you are suspecting, you have a fever, many inflammatory markers going up, and to prove that it is post-COVID inflammatory syndrome, you have to do a COVID antibody and show that he has contact with COVID earlier. So there are very few situations where you do an antibody test, but to decide whether you should take a booster or not, or whether, for such things, or whether you are protected or not, they are not useful.
Yeah,
And
I
even
think you're right.
As Anand sir was talking about, that even the anti-spike protein antibodies are also not very specific depiction of your immune status. They are just telling you about how your immunity has responded to probably a probable intervention or probably a intrusion, either by a pathogen or a vaccine. So I believe that we still do not estimate the right kind of antibodies. And as Anand sir has said, that over a period of time, no matter it is COVID or any infection, the antibody titers are going to go down. But there is some memory which is always there in your humoral immunity, and they are going to trigger both innate and humoral response over a period of time with the second infection or a second insult that you are exposed to, or an antigen that you are exposed to.
Right. I think you're right. Only in pediatric practice, perhaps, when you want to diagnose the multisystem inflammatory syndrome like Kawasaki disease. But now with the pediatric vaccination coming up, I think in the vaccine that also I think has no role to play. I feel from a clinical point of view,
probably there is one only area where you may get false positive results.
So besides that,
there
I
are
think
very few patients who are reported. I'm not I'm not a pediatrician, or nobody here is. So we are not authority to comment on it. But whatever I have read about it, sir, is that Kawasaki is one such disease where you can have false negative RT-PCR, false positive RT-PCR in a negative patients as well. So that is what is.
Yes, Mangesh, I think since you're talking of S-gene target failure, what are you talking about? What is this S-gene target failure? How it is important?
Yeah, that's a very useful, very interesting area. Actually, we all learned about it when for the first time when Omicron was discussed. And we realized that is something called as an S gene target failure. Whenever we do any PCR, they target three areas, usually three target antigen analysis, and this S gene is one, which was specific for delta. If you remember, there was something called as an N gene also, which was specific for alpha. So, when this Omicron came, this S gene was found to be absent, and the RT-PCRs, they failed to detect this S gene, and that is the reason why it was called as an S gene target failure. So it is supposed to be the mutation of the spike protein S1, and that results into probably not picking up or of the target PCR estimating these S genes. This is what probably S gene target failure is, and non-S gene target failures probably immediately tells you that there is a possibility of either the Delta variant or a Beta variant that is possible. Even in alpha, sometimes S gene target failure is reported, but it is more N gene target failure rather than an S gene.
Right. I think when the mutation occurs, there can be either gain of function or a loss of function.
Loss of function.
When you have loss of function, you talk of this target failure.
Target failures, yes.
Now,
Can I add to that a little?
Yeah, sure.
Yes. Now, unfortunately, what is happening is that the BA2 variant of Omicron is gaining predominance, and the BA2 variant is not showing S gene target failure. So we can no longer depend on that also now.
Right.
So short of genome sequencing, it's very difficult to identify.
No, but sometimes just cut short of this, the Tata company also has launched a product called Omicron. I think, Anand, you can tell me a little more about Omicron.
Yeah, this is, I don't have personal experience of this test, but it has been launched, approved by ICMR. In fact, ICMR and Tata work together on this. And it has been launched at a very economical rate also, 250 rupees a kit. And it's a fairly fast RT-PCR.
Yes.
Basically, they check the S gene, and they also check the mutated antigens of Omicron, mutated genes of Omicron.
Amplification.
So they are going
amplification.
So they will amplify the normal S gene also. And so if that is absent, then that is one hint that it may be Omicron. But that's not all. They actually detect the genes of Omicron also, the S gene of Omicron. So they will be definitely, avoiding the need of genome sequencing to diagnose Omicron. And this test, and it does have clinical relevance if we have this test widely available, and you can be assured that it's Omicron, your treatment is going to differ.
Yes. And secondly, the turnaround time, it is called TAT. It is just less than 24 hours. Yes. If you want to do sequencing, it takes about 7 days.
Yes.
Right. Therefore, you get quickly the answer, and then you can identify also. In a crucial case where you want to differentiate between Delta versus Omicron, this is an Indian innovation, and which recently approved on the 4th of January. It was approved, and Dr. Ravi is the main person behind this who did this, and I think we should always get credit to what is discovered in India. So this is a good discovery. That's why I thought we'll include that question of Omicron. I think, okay, then let's come to the lot of tests, Dr. Agam. People ask D-dimer, ferritin, CRP, HRCT. You think you would advocate this? It is a waste of time, money, energy, and exposing the patient to the risk of infection necessarily.
The COVID taught us many new things. I was very much for the first time came to know about a virus actually acting as antigen. Virus hardly created. As I always felt, the virus has a tremendous potential to hit your immune system, and it puts you into that hyperimmune phase. A few of them go into that cytokine storm and lose lives. I always give example, like you have 3 students or 3 children, playing in garden, and then there is some pollen exposure or dust exposure, and all 3 of them may have different reaction to it. Somebody may not get affected at all. Somebody may have just sneezing, and somebody may have acute attack of asthma. It's not that dust, it's not that allergen, it's how your immune system works decides the cause. Similarly, in this variant, earlier we felt the earlier variants had a tremendous potential to each immune system and had the potential to let patient go into that hyperimmune phase of the cytokine storms. We learned a lot. Earlier, in fact, we started asking for this test very routinely. In fact, almost all patients. I remember asking for it in almost all patients on day 3 and day 7. And then gradually we learned that we were overdoing it. We don't know the natural behavior of IL-6. We do not know the natural behavior of various, these inflammatory markers, whether they rise before they fall, whether they go hand in hand with, like what I have as a chest physician. You may have a pneumonia. Patient may be clinically improving, but radiologically he may be deteriorating. And there is something called as radiological lag. Similarly, we don't much know about this. And hence, then as we got wiser, we started asking for it less and less. So my today's practice is not to ask for it on day 1 for sure. If at all, I would want to do this test if patient is going into that hyperimmune phase. And how would I suspect hyperimmune phase? If patient develops any new symptom on day 3, day 4, day 5, if he starts getting cough, which he did not have, if he gets another spike of fever, if he gets shortness of breath, or if he gets feeling of unwell being, probably that is the time I would ask for this test. Otherwise, I don't ask for this test anymore. Thank you.
Very good. I think it's also important to realize a lot of patients who have a prolonged COVID symptoms. They have this cough, they have breathlessness, tightness of chest, weakness, fatigue is the most important feature. Most of these patients carry on for a long time. It is believed it's because of the interleukin-2 levels and also interleukin-6 levels. In fact, there was a study done to use statins now, especially pravastatin was used, and they realized that it decreases the levels of interleukin-2, interleukin-6, and get some benefit. So therefore, there's some role of statin also in the management of patients of COVID. Okay, I think after having made a diagnosis of Omicron, after having understood how it is different from Delta, let's come to therapy part of it, which is much more interesting to all of us, and almost all the listeners are waiting to listen from you all, the expert opinion. I think I'll begin with you, Anand. Given a choice, have you ever seen a patient who's 25 to 30 years old, male patient, has no comorbid condition, has come to you with history of fever, and you are tested, suppose you have done a sequencing and you found it's Omicron positive. What would you do? You will give remdesivir, you will give them the oral tablet of molnupiravir, or you say, no, okay, I'll just give you symptomatic treatment, I will not do anything else.
Yeah, this age group 25 to 30 with no comorbidities, and if say Omicron is done or sequencing is done and it is definitely Omicron, then all he needs is symptomatic treatment, according to me. At this, because this probability of such a person developing serious disease is almost negligible, and he just requires a careful watch for the next 7 days. That's about it. Symptomatic treatment would be.
So when would you consider molnupiravir? It's now available. There are more than 8 companies are manufacturing in India.
Yeah.
So they just spend few thousands of rupees, and patient also feels you're given some medication.
Correct.
When would you use?
Yeah, this unfortunately a big controversy was created about molnupiravir. It was launched with great fanfare, approved by DGCI, and just a few days later, ICMR senior official went on primetime TV and said it's a very dangerous drug, it's a new drug, it may have side effects, and etc. So now we have patients asking us, if you write molnupiravir, is it safe? Should I take it? If you don't write, they'll say, why not molnupiravir? So it has put the practicing doctors in a quandary. So few things are very sure. It is not to be used below the age of 18 because it can damage the growing cartilage. Second thing, it is absolutely out in cases of, say, in pregnancy and probably somebody planning pregnancy. So all this is in the young age group. But above 40, I feel it's a safe drug to use. The fears about drug causing mutations, according to me, are overblown. In 5 days treatment, it's not some chemotherapy drug or something. And so above 40, and especially people who have comorbidities, I would definitely use it. But young, healthy patients, I am not going to use it.
So according to elderly patients, more than 60 or 50 with a comorbid condition, either because of obesity, diabetes, hypertension, you feel you want to prevent admission to the hospital, you would get away with the tablet, which is just a 5 days course.
Or maybe patient is not getting symptomatic relief.
Or it's a
continues
patient
to have
choice.
fever.
Yeah.
And usually, we still are under the discussion that maybe possibly that early use of molnupiravir in such kind of high-risk population might reduce down even the transmission. because now here we are not talking about the patient safety, but now we are talking about the community safety. And if the virus is there on board, we need to have something to even stop the transmission of the disease. That is probably one of the ways which is explored, which is still in debate, in the medical community.
Okay, so I think this is the place where you can place it, use of the molnupiravir. Now, since Mangesh, you are there, I would like to ask you about the remdesivir. When would you use remdesivir? Now, with the new study of the early use of remdesivir, because remdesivir has undergone a lot of turmoil, and in the past was used for unvaccinated patients. Now we see more than 100 crore Tikakaran, which Ms. Narendra Modi talks about. That means majority of the patients have at least got vaccination. Would you use remdesivir now in these patients? And how would you look at the benefit of remdesivir versus molnupiravir?
So a great question. Now, there are set indications for the use of remdesivir. And most importantly, what we do in our practice or clinical practices, these are the drugs for surely not for the OPD patients, those who are mildly symptomatic or asymptomatic, and young patients without any comorbidities. Remdesivir is out of questions. Remdesivir is usually for the patients, those who are hospitalization requiring patients, those who are showing the signs of the clinical worsening, or there are signs of lung involvement or possible suspect delta at the background. And probably there is a lung involvement, hypoxia, or sometimes in the patients, those who are intensive care requiring patients, or the patients, those who are, very high risk patients, like transplant patient or associated comorbidities like diabetes, obese, elderlies. These are the patients where still remdesivir will have a role to play. Otherwise, in the routine garden variety, mildly symptomatic COVID patients without any comorbidities, especially in the OPD practice, remdesivir is out of question.
Now, given the choice between these two, molnupiravir and remdesivir, the data says that remdesivir, when used early, this is the NEGM data. It's looked at about 500
I have seen that paper,
patients.
sir. I have seen that paper, but if you remember that data which is come is for the very small number of the patients, and that too, there are no head-to-head comparisons between remdesivir and molnupiravir together at present. And if you really look at all the three drugs, probably Paxlovid has got a still better data, and the hospitalization requirement reduction is far more in comparison to even remdesivir or molnupiravir. Now, if you really ask the numbers, probably molnupiravir has got little better hospitalization reduction than remdesivir, but still remdesivir.
No, I think remdesivir is better, 87%.
Better, yeah, sorry, I said exactly the opposite way. So remdesivir has a better, but then remdesivir still has to be smartly used in the practice. I'll take that.
Okay.
Now I would like to have comments from Agam. And
yes, what do you say, Agam? Will you agree with what?
I never had soft corner for remdesivir. I'm in literature, everybody knows, studies, everybody knows, but then I'm talking about my personal feeling. And I always felt if we start antiviral early in the course, we may prevent a lot of admissions. In fact, you would be happy to know that, sir, just when COVID came, just when we were struck with this pandemic, we at Academy, me and Mangesh both were party to it. We have published a paper in our IMA journal, GMA, saying that any patient who presents with flu-like symptoms during pandemic must be treated as COVID unless proved otherwise. And I'm of the opinion, and I'm of the strong opinion, and I quote, you must put these patients on antivirals if clinically this patient requires antiviral, right at that stage, pending reports. You can always take otherwise division. Suppose if you get Rtpcr negative, or suppose if you get alternative diagnosis by second or third day, you can very well stop this drug without completing the course, are my views. If we do this kind of practice, a lot of admissions can be prevented, a lot of patients can be managed on OPD basis. When I have to talk about 3 days therapy of remdesivir versus molnupiravir, I think I'm very happy using molnupiravir, which I've used almost in 26 patients so far. What I do is, any patient who does not respond to my conventional line of treatment over next 2 to 3 days continues to be symptomatic. Any elderly patient with comorbidities and who have a potential to develop serious disease are the candidates for molnupiravir, and I'm very happy using it. I've not come across any side effect. Imagine a drug where you don't have to make any dose adjustments, even in presence of severe liver disease, even in presence of severe renal dysfunctions. I think it is a boon to me. Thank you.
And I think to avoid the confusion, we can say that remdesivir is also proven to be effective and useful. We use early as per data from NEJM, and it is 3 days. It is again outpatient treatment where the patient need not be hospitalized. That is what has been said, but only thing is injectable. Of course, we know all the side effects of remdesivir. And molnupiravir, of course, cannot be used for young patients, in patients who are in the fertile age group, those who are planning pregnancy, or during pregnancy, you can't use it. Elderly patients, more than 60, and have a comorbid conditions, I think molnupiravir would be a good drug. Now let's
where probably
turn.
molnupiravir cannot be used, you can consider remdesivir. That is.
Yeah, I think the patient preference is that not to have injectable but oral. And again, I think you can tilt towards molnupiravir. And we'll not discuss Paxlovid because it's not available in this country. So for the time being, we will not discuss about this. Let's come to the role of monoclonal antibodies. Now, Anand, what is your experience of monoclonal antibodies? You think that Omicron can be treated by monoclonal antibody if the patient wants a treatment very early, doesn't want to suffer that exhaustion or a tiredness or a fatigue, doesn't want to go through all this dry hacking cough or a bit whatever symptoms that he has. You think that he is affording and you want to give him the monoclonal antibodies. Would you like to give it that?
With Delta, we had excellent experience with monoclonal antibodies, and it led to good resolution of symptoms and defervescence of fever and prevention of complications. And the results were obvious within 48 hours. Monoclonal antibodies could be given and patient could be sent home, so it need not be admitted also. But unfortunately, the only monoclonal antibody cocktail available in India is not effective against Omicron. Monoclonal antibodies are highly specific. They will act only against a specific part of the spike protein, which is about only 8 to 10 amino acid long, only that region. And if there is a mutation in that sequence of 7 or 8 amino acids, that monoclonal antibody will not bind with good affinity. So in fact, to prevent that, this was a cocktail. It contains 2 different monoclonal antibodies, casirivimab and imdevimab. They bind with different regions of the receptor binding domain of the spike protein for this purpose, to so that at least one of the antibodies will act. Unfortunately, in Omicron, there are some 15 mutations even in the receptor binding domain. And these antibodies have lost their affinity. How do they study that? They basically study with a pseudovirus assay, wherein a different virus is, a gene for the S protein is inserted into that virus. And then that virus starts expressing the spike protein on its own surface. And then this antibody is allowed to interact with the virus and see if it can neutralize the capacity of the virus to bind with the ACE2 receptor. So using this pseudovirus neutralization assay, the company itself, Regeneron itself, has concluded that this antibody cocktail does not work against Omicron. The binding affinity is very, very low, to the tune of 60 times lower as compared to binding of Delta. So obviously that option is now out as far as Omicron is concerned. Sotrovimab is the only monoclonal antibody which is active against Omicron, but it is not yet freely available in India unless some patient imports it or something. That's a different issue. So it's no longer, it's no longer available.
I'll push a little hard, Anand. Do you think that the excessive use of these monoclonal antibodies have resulted into mutation of the virus? Is it the virus mutation is the effect or the result?
No, in fact, I definitely would say no. That the thing is this, they have done a very interesting study. They took viral samples at the beginning of illness and 8 days after the illness has started from patients who were given monoclonal antibodies. And they took viral samples at the beginning of illness from the blood and 8 days after the illness has started among patients who were not given monoclonal antibodies. And they looked for mutations. Now, as you mentioned earlier, the RNA viruses are very fast mutating viruses. So in both groups of patients, whether they were given monoclonal antibody or not, they found that almost 10 to 15% of the patients showed some mutant viruses after just 8 days into the illness. This is because virus evolution takes place so rapidly. There are millions of copies made every day. So small errors of copying, they go on multiplying, and mutations are found. So there is no extra increase in mutation by giving the monoclonal antibody. Yes. Now what will happen is, we are worried that whether a mutant is going to be transmitted to somebody else. Okay. Now consider a scenario: a patient has got monoclonal antibody. That means he's already a diagnosed case of COVID, and that patient by definition or default is isolated. Others are prevented from coming in contact with such a patient. So you would not expect that patient to develop a mutant and transfer it to somebody else because of this very reason. Okay, so only place where mutation in a patient may infect others would be patient in whom the virus will continue to multiply for a long duration, 3, 4, 5, 6 weeks, like patients with HIV or other immunocompromised patients, where the virus would survive in his body for a long time and come out with different mutants to infect others, etc. So per se, monoclonal antibodies will not impact significant mutations in the community. And finally, of course, it's an expensive drug, not like a mass use to worry that it will cause resistant mutants to arise. That is my opinion.
Yeah,
And
in
sir,
other words,
very interestingly,
because of the HIV infection, who have been immunocompromised, the virus tends to undergo multiplication and eventually result into a lot of mutation. And that's how these mutations can be transferred. But people do not want to use this HIV infection as an example, because then you discriminate between the HIV and non-HIV patients. So therefore, I think that's one. And second, there's a very good example of what is called as the white-tailed deer, which is the external animal source in which there is a zoonotic infection. And this undergoes a mutation there in the white-tailed deer. And that is infecting back to the human being, which is called a reverse zoonosis.
Yeah.
And that is also one of the ways in which you can have these kinds of manifestations. All right. So I think,
in fact, sir, if you allow me, what Dr. Anand said, just to tell you that there was a very interesting study which was done during the peak of the Delta pandemic, where people were also getting vaccine. This is a study from Russia and Japan, both places. They tried, a shot of a vaccine, and while they were getting vaccinated, these people were also given a shot of a monoclonal antibody, especially Casiri-MDV combination, and they studied, how the patients are protected well, because till the time the immunity develops, really, they wanted to keep the population safe. So during the high time of pandemic, even they tried this. Now, the data was quite mixed there, but as Dr. Anand has really rightly, beautifully pointed out, that this doesn't push patients to develop mutation. The reasons for the viral mutations are far more different than probably them.
I think it's more of a biology.
That
yes. Is for their survival. Unless they mutate, they can't survive, because the antibody will wash them off. And even if the antibodies decline over a period of time, the T cell response, which we don't count, we have no measure to find out what is your T cell response in the body. So that will protect you, though the immune status is not qualified by looking at the antibodies alone.
So that is one memory, humoral response.
Yeah, the memory continues. All right. I think after that discussion of the monoclonal antibodies, let's come to some simple basics. Anand, I think Dr. Agamora has to leave, so he has left it. So we too can continue for another half an hour. It's okay? Both of you?
Absolutely fine.
Okay, all right. So let's look at this healthy lifestyle. We hardly ignore this part: the adequate sleep, the good nutrition, a lot of emphasis on the zinc supplement, and so on and so forth, the healthy diet kind of thing. What do you think the role of these things in preventing or in tackling the COVID infection?
Yeah, basically, what I would say is this, that yes, it is true that if somebody is deficient in vitamin, say vitamin D, deficient in, say, nutritional elements, and therefore in a weaker position of health, that person contracting any viral infection or COVID for that matter would be more at risk of developing a serious infection as compared to someone who is in a healthier state. But that does not mean that by taking supraphysiological supplements, doses of vitamin D or C or zinc or
Right.
anything, you can develop some sort of super immunity and not be infected with COVID. If under that impression, then that's not correct. So it is important to correct all your deficiencies, be in a properly controlled state of diabetes, your BP should be controlled, any comorbidity should be optimally managed. Then you are in a better state of health to face any sort of viral infection. And that applies to COVID also.
And in fact, so one of the reasons, probably possible reasons, this is what is my interpretation is, or the high number of mucormycosis cases reported in India is basically overzealous use of zinc along with the poor sanitary conditions. Because we all know that zinc is necessary for the fungal cell wall development. And sometimes, that can spread the fungal infection.
Right. And adequate sleep is also essential. Their study looked at the people who sleep adequately versus those who don't. The T-cell response is far superior in people who have a good adequate sleep. I think it is important to have a good 7-hour sleep, good lifestyle, good nutritious diet, exposure to sun, and if necessary, supplementation of vitamin D if the patient is deficient. But supplementation of zinc has no role to play. There's a very typical clinical question. One physician called me about 2 days ago. He has had fever for 2-3 days. He took molnupiravir, azithromycin, ivermectin. The fever went off for 2 days to reappear again on the 6th and 7th day again. So he tested his antigen, which was negative. It can be tested at home, which was negative. He repeated Rtpcr test negative. He's worried about why this fever has come again after 8 or 10 days. How do you explain this fever, which come back after having had the effervescence for 2 to 3 days?
Yeah.
Anand, anybody?
Yeah, go ahead, sir. Anand, yeah.
Okay. I'm assuming at first he was positive, right? You said.
Yeah, he is positive.
Okay.
Yes, positive.
Okay.
Yes.
Yeah. So this would be a classical sort of indication to look for a hyperinflammatory state. I mean, the first 5, 6, or 7 days of COVID illness are the viral phase, and most people would be cured after 6 or 7 days, and they would not get a fever again. So fever developing after 6th or 7th day is an indication that patient may be going for hyperinflammation or hyperimmune or what we call cytokine storm type of pattern. So this is a place where we have to do test ferritin and CRP to check. These two tests indicate that hyperinflammation is taking place. Then this is also the place where I would do a CT chest and a D-dimer to see presence of hypercoagulability. Interleukin 6, normally the people are doing right and left and center, but here it would be indicated. So if these indicators are there, then this is a patient who is a candidate for probably steroids and anticoagulant, etc. So this is fever is a very important marker because you should not get fever again after 7 days. Super infection is less common in COVID, and it's not the first thing to think of. If the fever comes, think of cytokine storm.
Yeah, initially, especially if there is a clinical association.
Yeah,
there is a clinical association. So as Dr. Anand has said, that we need to be extremely careful, but at the back of the mind, you need to always have to, keep that in mind that, during the same time as we are working out this patient for the development of the worsening of the disease per se, but we need to also see to it that, you have adequately ruled out the other causes of fever also.
Yeah, especially a bacterial infection is also possible. Existing sinusitis or another infection is possible, that has to be kept in mind before we think of talking about either cytokine storm or
simple seasonal infections coming up that time.
It's also possible because the patient was very comfortable. So I said, don't worry.
So we need clinical assessment of this patient along with probably the hematological parameters would definitely help in these patients.
Yeah, there was also a question, should we get a procalcitonin done in these patients and a D-dimer along with this is what Dr. Krishna has said. I think he's right, because if you suspect a bacterial infection,
you need to work up this patient as a patient of fever and how the approach has to be.
Yes,
so you need a gamut of investigations along with all the possible parameters.
Yes. Okay, I think after having done that, we have another 20-30 minutes or so. We have enough time to discuss about vaccines, which is again a very important question. Now let's talk about the vaccine for giving protection. And if you look at the Ethiopia as a country which has zero vaccination, and it has a zero incidence of either Omicron or any infection. So we don't know how to explain this. But if you see Omicron, the infection came in all those patients, whether infected or non-infected, or whether it vaccinated or otherwise, young or old, male or female. So it didn't bother about anything else. So what is this infection of Omicron, which doesn't bother about the state of immunization? How do you explain that?
Anand sir?
Okay. Omicron definitely has shown itself capable of immune escape. What has happened is, in fact, the vaccines, when they first came in, the studies were done to show that it prevents infection. Okay, and especially for mRNA vaccine, they claimed a prevention success of as high as 90% and above. And to some lesser extent with the vector vaccines, and to a lesser extent with the killed vaccines.
Covaxin, yes, Covaxin.
But these studies, if you see, they looked at chances of infection within the first few months, at the most 2 or 3 months after taking the second dose of the vaccine. So this is the time when your antibody titers are at their peak, and vaccines were able to prevent infections. But as months went by after taking the vaccine, the antibody titers go on dropping. And it is extremely difficult to prevent infection, especially a respiratory tract infection, because the antibody titers go on dropping. So then it was for the defense of the vaccines, it was shown that it is not the prevention of infection, but the prevention of serious illness and reduction in mortality, which are the main benefits of the vaccine, which may remain there for several months to a year after the vaccine. And this, as Dr. Mangesh and you pointed out earlier, is due to the T-cell immunity, which is persistent, even if the antibody titers have dropped. So Omicron has shown absolute escape from most of the vaccines. And that is why this campaign for booster was started especially in US and Israel and in Europe. Even with a booster, in India, we have seen cases of Omicron coming up even with after booster. And so now I think it is time to be honest with people and with patients that vaccines are more important to prevent serious illness rather than making claims that they are important to prevent infection totally.
I think they can only prevent disease, but not infection. You can get infected, but you won't get disease. You won't get hospitalized. You will not require oxygen or a ventilator, but you will only get the symptoms of fever. And so infection is possible, but disease can be prevented. So that is ultimately.
And in fact, the common thing that I tell to my patients is, that vaccines are like just your car seat belts. They will not stop you from getting accidents, but they'll definitely, in case of accident, probably the chances of sustaining the serious injuries would be far more lower in comparison to, the unvaccinated population.
So I think we have now the Omicron specific vaccine, Dr. Mangesh.
They have been talking about it, sir. And
the Moderna is now trying to do it.
Yeah, Moderna is coming up. Now Pfizer BioNTech is there. Now for children also, and it's supposed to be
they're thinking of getting some in mid-March.
Yes, mid-March.
By the time I think by the time probably
the epidemic will go down, the pandemic will go down, and Moderna, I believe, it doesn't develop into a new mutation. That is what we are praying at present, at least.
There is a rule called a Michael rule. which means when any epidemic comes at a peak, at a sudden peak, it drops also with the equally sudden trough, or there is a sudden downfall. So like Zika virus, we studied so much, we could get the vaccine. By the time the vaccine was ready, the Zika virus disappeared. Totally.
It's the
So
rule
it
of
is
pandemic,
possible.
sir. If you really see the Spanish flu pandemic history, you will see that it typically lived for that 2 years, and these mutations only, killed the whole sequence of the virus. So, and the mutations kept on happening so much that it was difficult for virus to survive. So probably this is the same trend which is possibly seen, if at all we wish and pray.
I think we should start a branch of virus astrology.
Yes.
And then we can start predicting as to what is likely to come, what is not likely to come. I think it's anybody's wild guess.
Yes.
Because we now felt everything is over. And by the time we started relaxing, we also started having conferences. And then the Omicron crept in.
Yes.
And I'm not sure, and I'm not really sure whether the next mutation is also on the board. We just don't know. I think we have to wait and see. Okay, now, Anand, there is a lot of discussion on the mix match, or what is called as a hybrid vaccination. You begin with Covishield or a Covaxin, and then when you want to take a booster dose, you would rather prefer the one which you had not taken earlier. But the government of India is now insisting that you should take the same vaccine which you had taken earlier for the 2 doses. So what is your view? Will you think that the mixed match view would be better to get a better immune response? And if so, why? Why you get a better response?
Yeah, this has actually been studied. In India, it was studied by accident when some patients who were given by accident a different vaccine compared to the first dose that they had taken. And these cases were studied by ICMR, and they found that they had developed excellent antibody responses. Whereas abroad, they have deliberately done mix and match studies where they have used the mRNA vaccine followed by your vector vaccine and vice versa. In both the cases, they found excellent antibody responses by mix and match vaccine. The reason behind that could be that, for example, a spike protein vaccine would generally produce very high levels of antibody, and it's highly immunogenic compared to a killed vaccine, say like Covaxin. But a Covaxin will have all antigens, not just the spike antigen, because it's the whole virus. So it will have S antigen, it will have N antigen, and everything on its surface. So it would produce antibodies against multiple viral antigens. So each vaccine will have its own advantages, disadvantages. Killed vaccines like Covaxin, we found antibody titers were not very high as compared to, say, Covishield. But the advantage is multiple antibody generation. And the advantage of this vector vaccine or mRNA is very high antibody titer, specific and neutralizing antibody titer, and higher probably T-cell immunity. So if you combine advantages of 2 different vaccines, my personal opinion would be it would be advantageous. Now, sooner or later, it should be permitted even in India, I suppose.
No, Anand, just to extend,
And sir, one classical example of even an existing vaccine was a Sputnik. Was a typical mix and match where 2 different viruses were injected.
Adenovirus.
And they generated the 2 different responses, and they thought that yes. So that was a brilliant thought, as a matter of fact.
I think vaccinology is a very interesting branch and a very, very illuminating branch.
Yes.
Now, Mangesh, I have a doubt. See, even in the RNA vaccine, which is a unique vaccine, tried for the first time in the COVID pandemic, you have 2, the Pfizer-BioNTech and the Moderna. Between the 2, the Moderna showed a superior response compared to Pfizer-BioNTech. You have any answer as to why this is different? Both are same RNA-based vaccine. Here, at least we have Covishield and Covaxin are different. One is a spike protein, the other one is a killed virus. So it's likely that it's going to have a different immunogenicity. But when you have RNA only as a use of vaccine, or the way it is developed as a vaccine, why this should be different?
No, as a matter of fact, I'm not really truly sure about the answer about why this has happened. It is for sure happened.
Yeah, it's happened.
It has happened for sure. So I don't have a real answer for that.
Anand, you have any answer?
What I thought was the difference is not so high. That's 94% versus 91% prevention. That's what I have read.
That
Because
is a
both
study,
are that
but
way very similar. They both have a nanoparticle lipid particle
Lipid
for
particle,
delivery,
yes.
and both have mRNA coding for the spike protein, and that they should ideally be
the
identical.
difference
No,
was
and if you
quoted because
remember, sir, no, the paper at the footnote writes down even that even the authors are not able to tell why this has.
the one speculation is that the dose is different. They use Moderna at a little higher dose, so the
Yes.
antigenic load was a little higher, and the duration between the two doses was
doses
also
could be.
different. In Moderna, it was a little later, and in Pfizer BioNTech, it was a little earlier.
Earlier, yeah.
So the duration between the two doses and the initial dose was different. That's why they felt that the Moderna was better off in terms of the immunogenicity, primarily because of the excess load of the antigen which was injected to these patients. So let's come to the children and vaccination. What is the status of vaccination in children? Now we have in India, the vaccination open for the age of 17 plus, I guess, not 15,
Yes.
17 plus.
17 plus.
What about the people beyond below 15 or 5 to 15 or below 5? What is the status? Will there be any different kind of a strategy to vaccinate these patients? This pediatric practice, now we'll see that the pediatric infection also increasing. There's a paper from I think Texas, which showed that there's 64% increase incidence of hospitalization of the pediatric patient because of COVID infection. And this class is not immunized. In the Western countries, they have below 5, it's not immunized. Above 5, they started immunizing. So what is your view? What is likely to happen in this country? What do you view it as? If you're a policymaker, what will you decide?
As far as Indian subcontinent is concerned, we are surely open. We have started vaccinating kids above or teens above 18 years for sure. And now, or even now 15 years, I believe, right, sir?
Yeah.
Bhave, sir? Yes, 15 years now we have started. 15 years and above.
15,
and below, I think below 15 years, they have not yet approved any vaccine, especially in India is concerned.
Because
but I'm sure that by and large now, the only vaccine which currently has approval is Pfizer BioNTech, sir. That is the only vaccine probably.
India, they are thinking of using Covaxin.
They are thinking about using.
Kill vaccine.
Yes.
And therefore,
they are
that is
thinking
now
about using, but they do not have a robust data still to prove the safety. And
they're not started, I think.
Yes, they are not.
Once they start, I think we'll get to know.
I think Indian policy has been extremely balanced and sound.
Yes,
we started by vaccinating the senior citizens and healthcare workers. Of course, this was all over the world.
Yes.
Then we have the tried and tested killed vaccine platform, age-old platform, which we are trying in the younger population and in children. Because there have been, as Dr. Vijay said, mRNA is first time this vaccine technology has been introduced for mass vaccination. There have been so many worries about it.
Yes.
And to try directly in the pediatric population, there are some concerns about long-term effects and all that. So our Covaxin strategy should be the best or the safest at present that we can think of.
Yes.
And there has been actually concern why we need to vaccinate children when they don't get severe disease. But definitely with sound, proven and tested technology of vaccine, yes, we should gradually proceed towards vaccinating children.
Yeah, because nobody's
the concept
immune
is same
against
like influenza, sir. It's like the concept is same
and
as
nobody's
influenza
immune.
vaccine.
Yes. Right. And I think we are waiting for the next generation.
And as Dr. Bhave has said beautifully, sir, that our mechanisms are fairly sound, and we stuck to the basics, basics of clinical learning that we had. Our previous experiences with virology, we did not break the rule. If you really remember, when the world was, damn opposite use of steroids or use of even nebulization, or they were for pro ventilation. It was the Indian data which has come up that follow the same viral ARDS protocol in these patients, and that will be beneficial. And in the same viral ARDS protocols, we used steroids. Really, we used a fairly good amount of nebulizations and aerosol therapy. We also probably delayed the ventilation. We were the people, those who probably because of the limited resources, but ultimately ended up in delaying the invasive ventilation. But it proved to be really a good way of strategic management of the patients, and it has proved true over a period of time.
I think yes. I think Mangesh, you're right. We are wise because we are more clinically based clinicians rather than the lab-based clinicians. Because
Yes.
the Western world is more lab-based. We are more clinicians. I think we still follow William Osler, which I began my quote with. I think that's why I think probably our feet are grounded. We're not in the air. I think we are still waiting for the new generation vaccine, the third generation, the nasal vaccine, the dermal patch vaccine, and so on. So I think a lot of things will come. Maybe that time the pediatric coverage will be good. Very common question. I think people talk to you about the post-infection quarantine. The US says it's 5 days, UK says it's 10 days, France and Japan says 10 days, WHO says 14 days, India says 7 days. Now, there's so many confusion about number of days. People keep on asking you that I suffered from this, and then suppose the husband, wife in the family, the husband gets earlier, the wife gets little later. So the husband's is the quarantine period is out, the wife is still in quarantine. Now, how do you advise such kind of patient? What is the minimum number of days that the patient should himself or herself keep isolated following infection?
Yeah, basically I follow the government official guidelines, but personally this has gone, this has contributed to confusion, and this kind of thing, tends to make people lose faith in the official advice. The same, something about the same issue being told differently in different countries and at different times. The period of viral shedding, I don't think personally it is less in Omicron as compared to Delta. And earlier guidelines of 14-day, isolation were based on some evidence. I don't think there are specific studies about Omicron, how many days the patient sheds virus, how many days is infectious. But Omicron being milder, perhaps government has also reduced the quarantine period. And another reason for that is fatigue, the quarantine fatigue. We are going through this pandemic for more than 2 years now, and still it's going strong. And everyone is tired of restrictions and quarantine, etc. So 7 days is probably the minimum. And I generally follow the government guidelines. But personally, I do think that there is no study which says that Omicron viral shedding is less duration than Delta was or something like that. But as per government guidelines, I say 7 days. That's it.
Yeah, I think you're right. That makes sense because it avoids confusion and you stay with the government.
Yeah.
But my patient says quarantine means quarter at 9. So you drink every day a quarter peg at night. So that is my quarantine.
And then they'll ask for a prolonged quarantine in that case.
So that is a lighter range. Some people make adjustment as per their need. And that's a wishful thinking if they want to have that kind of a quarantine. But I think 7 days should be fine. More than 7 days is not necessary. Probably because the infection is so widely spread in the community. Yes. There is no need to test. There need to have quarantine also. Even those people who come from abroad, they no need to test the Rtpcr also. They don't have quarantine also for that matter. It's of no use.
Now few countries have started
disease is spread in the community.
The purpose of quarantine in the community.
Yes, the purpose of quarantine is to prevent the disease in the community. So it's already community spread, I think.
And that is what UK is thinking, and that is what
I think. That's what UK is.
They are leading the world in guiding the community. UK
is
leading the world
or misguiding. Actually, the common question, I think both of you can answer this. They ask me. There's N95 or KN95 or a surgical 3-ply mask or a cotton mask. Now, in the present state of the Omicron, which would be the better one? Means which would give them protection both to them and to prevent the infection to others. The mask has two purposes. One, forget themselves from getting infected, and if the person is infected, spreading it to the others.
Yeah, so we'll stick to the same, the practices that we followed during the Delta times, especially for the healthcare providers, those who are working into the COVID affected hospitals, or the people those who are exposed to COVID frequently. They should always follow the N95 masking or probably the double masking that has been usually advised. And for the common people, those who are not so much exposed and all that, probably a good surgical mask would be fairly fine. And when you are visiting a social gathering or probably the place where there could be a closed ventilation or something like that, then probably there you can, double mask, or somebody visiting a hospital or something like that. That is the place where probably you can double mask. These are the rules that we have followed, and we should continue to follow that. Let us not lower our guard for two reasons. Number one is this, that we are still not sure about how the next mutation is going to be. And secondly, that we are not very sure about is this, that how much lowering down your guard is going to harm you. So these are both the areas of concern at present. So let us follow the the guidances which are issued by the government and especially ICMR, and probably that would definitely serve the community. And most important thing, whatever I have observed in the practice, sir, is that by masking regularly and sincerely, it has also reduced down the load of other communicable and the transmissible diseases. Now that has really been distinctly noticed in our day-to-day clinical practice. All both of you must have noticed this surely. And I think that is another thing. Better hand hygiene has reduced down all those fecal-oral transmitting diseases. The gastro has gone down, the hepatitis has gone down. So much benefits that we have got it. So at least this has taught the community the discipline of what our probably the ancestors have kept on teaching us.
I think there's a question by an attendee. Is anonymous attendee says, "Do the vaccines really work? I have a sneaking feeling that the anti-vaxxers may be right this time." Anand, your opinion?
Yeah, as far as we already said, prevention of infection, no, they are not very effective, especially with the emergence of Omicron. But there is enough data now. We have been very closely observing the hospitalization data in UK, US, and even recently released from Mumbai, that if you see the number of patients in ICU, number of patients on ventilator, number of patients who have died, and see the proportion of vaccinated versus unvaccinated in them, it still is showing that the unvaccinated people are at more risk of serious illness than the vaccinated. So about prevention of serious morbidity, mortality, I still believe vaccines are effective.
Yes, and if you vaccine 70% of the population world over, maybe can blow over the disease like we have succeeded in polio, in smallpox. We could get eradication only with vaccination, because this is how the
unvaccinated people, they are the source for the community infection. So vaccination is there, extremely important, and definitely works.
It's important, and people should convert the anti-vaxxers to make themselves take vaccination.
In fact, funnily, if you remember, the first Israeli quote which has come when Omicron was out, that this is a natural vaccination shot for all those non-vaccine believers, where nature has taken care of giving them a vaccine naturally.
Yes, I read somewhere that Omicron creates antibodies which may even protect against Delta or other serious variants.
Yes, this was an Israeli scientist who came out with this statement, if you remember.
That's because any infection you get antibodies, right? Yes. This is the way, because this is a milder disease. Correct. People have the perception that the Omicron is a mild disease.
Yes.
You suffer it out, suffer for 1 week, get antibodies, it's equivalent to booster dose. Yes. So that was what the feeling. I think it's not true, because the mutations that I've seen are more than 50 mutations in this virus. So we do not know what kind of antibodies it is. And if the new mutation comes in, that will be useful for that. I don't know. I do not know how to answer that.
There was one question which was asked, do we really give a booster vaccine during the Omicron
pandemic?
When the Omicron is showing a vaccine schedule. My answer to that, probably, yes, we should still, because we are never sure about that when Delta is going to come back. And secondly, if it is not protecting against Omicron, fairly fine. Omicron is not causing that much of harm. But if at all, the vaccine prevents you from getting Delta, that is a big, I would say, achievement. And that is
Omicron itself might behave like Delta. Yes, that is also possible. Yes. That is also possible. So in that case, the vaccination is important. Doesn't matter even if you have just infection or pre-infection state or in incubation period. I think you should take the vaccination. That is my message. So I think before we close, we have just 4 or 5 minutes left here. I think both of you, the key messages to the listeners, that what would you think or what would you tell them about the Omicron, and possibly what is the future predictions of yours, and what are the hopes for the future?
Yeah, so primarily my message is this, that yes, Omicron has probably taught new things to all of us, and maybe that the therapeutic approaches might have changed, but that has come as a relief from the Delta pandemic that we had. But at no point of time, do not ever lower your guards as far as the safety and the approach to the disease is concerned, and be always watchful when you are managing the patient. There is still alluring threat of Delta, which is not completely eliminated. So the best way is, believe in the good practices which have been recommended by the ICMR or the governing authorities, and encourage vaccination in your community, because currently the only two time tested sure shot preventive measures are usually COVID appropriate behavior and vaccines. These are definitely proved to be beneficial. Do not lower your guard. Do not be complacent. Be always watchful. And probably we'll keep on learning more and more. The ideas might change over a period of time. We'll still keep on learning new things. But currently, at present, this is what we all are aware about it. And we must stick to whatever the knowledge that we have currently.
Anand, your message?
Yeah, I think we all need to take good care of our basic health issues. If you have blood pressure, your heart problems, your asthma, your diabetes, control all your diseases optimally. Be adequately supplied with your necessary vitamins, and do your exercise, because somebody in good health can tolerate an illness much better than somebody in poor health. And please do look after your masking, keep hand hygiene habits intact, and avoid enclosed spaces with big crowding. Even today, from Noble Hospital, Pune, the data is 10% Delta and 90% Omicron. So it's not yet over, but it will be soon.
Right.
And your message, sir.
Yeah, like I think I've written down few messages. I think the lesson that we have learned from the last 3 years is that RNA viruses mutate, especially with unrestrained multiplication. Masks and vaccines work, some better than the others. Like immunity to seasonal coronaviruses, immunity to SARS-CoV-2 wanes with time. COVID-19 vaccines are better at a disease blocking, less so to infection blocking. You can get infection, but you don't get the disease. Single antigen vaccine against RNA viruses are not optimal over the mid or long-term period. We foolishly think that we understood coronavirus and that the pandemic is over. More variants will certainly come. It's not still over. We have the antivirals, which are effective used early, the remdesivir and molnupiravir. The COVID appropriate behavior, as Dr. Mangesh has said, is the most important step. Masking is very important. Monoclonal antibodies also have their definite role in the treatment of these infections. And the human behavior distorts the compromises of a rational responses. So therefore, the appropriate behavior is very important to curtail or to mitigate the complications of this infection. So with that, I think we come to the close. Before we close and hand over back to Dr. Vijay Sethi, I think I must thank immensely Dr. Mangesh for giving us extra pearls of wisdom. And my good friend and colleague, Dr. Anand, also was giving a lot of information and a lot of new learning from this particular discussion. I learned a lot. I feel enriched. I guess everyone who were participating in this meeting must have learned so. So thank you once again. And thank you, Krishna Sheshadri, for this great opportunity. And Dr. Vijay Sethi for coordinating with me every time, gave me all kinds of inputs and to see that the program is great success. Over to you, Dr. Sheshadri and Dr. Vijay.
Good evening. It was an excellent session, and I thank Dr. Neglukar, Dr. Mangesh, Dr. Anand, and Dr. Vora for conducting this session. I think you all have covered right from what the virus is, right till the vaccine stage. It was an entire analysis of the entire thing, and it would have been a great learning experience for all the participants who have been, because everything has been put into a nutshell. The learnings of the past 2 years has been condensed in this 1.5 hours. And I thank the panelists a lot for taking time out and sparing in.
Thank you.
You know,
Thank you. I think we could finish
Thank you
in
so
time,
much.
I guess, just 4 minutes beyond the time that was allotted to us. Kindly
Yes.
excuse us for that.
No, that's fine. Thank you so much.
Thank you.
Thank you.
Thank you so much,
Thank you.
Dr. Jay Neglur. Thank you, Mangesh. Thank you, Dr. Bhave. Thank you, Agam. This has been just wonderful. I can't expect, I can't say anything more because, we needed this wisdom. I think you have given it right, and I'm very, very grateful. Thank you so much.
Thank you.
Krishna. Thank you very much. Thank you, Neglur sir.
Thank you.
Let us put on record excellent moderation by Neglur sir.
Oh,
He's been
thank you.
always phenomenal as the way he is always.
Oh, thank you. Thank you very much.
Thank you very much, everybody.
Thank you both
Krishna.
of you
Thank you,
for
Dr. Mahesh,
contributing.
Dr. Vijay, and Anand sir. Thank you very much. It was a learning for me. Thank you very much.
Thank you.
Bye bye. Good night. Stay safe. Stay happy.